Good day, everyone, and thank you, Mr. Chairman, for the kind invite and the kind introduction. Let me pull up my slides and share. Perfect. Okay, so it's an honor to introduce the recent discoveries in the field of thyroidology for this great audience of the Jordanian Thyroid Diabetes Endocrine Society. So we're going to address the new innovations in the treatment of both Graves' disease and thyroid eye disease. In the field of cancer and the new guidelines that were released in 2025, this one will also be presented. So let's start off with hyperthyroidism. So this is a study indicating how do you pick up patients with hyperthyroidism in admissions with atrial fibrillation. So that was published in the JCEM. And patients who were in hospital admission with atrial fibrillation, some of them did develop or were found to have hyperthyroidism. So this study came up with a risk calculator that you can plug in some variables and get how much of a chance would a patient be having hyperthyroidism. So most risk factors were correlated with the development of hyperthyroidism in atrial fibrillation patients where age above 65, gender being a female, the fact that a patient had a stroke, end-stage renal disease, and CHADS 2 score. So this is the risk calculator. You give each a point. So gender being female, age above 65, you give 1 point to. The presence of diabetes, the presence of hypertension, presence of end-stage renal failure, heart failure, congestive heart failure, and CHADS 2 score. You score CHADS 2 status. So the higher CHADS 2 score, the higher score you will be getting. So if you look here at the top left corner, a CHADS score of over 3 was correlated with hyperthyroidism. However, a CHADS 2 score less than 3 was correlated with being free from hyperthyroidism. So the incidence of hyperthyroidism could be calculated based on the points you generate from this risk calculator. So the more scores you have, the more points you achieve, the higher the incidence, up to 10%. You reach up to 10% incidence of this patient having hyperthyroidism with atrial fibrillation admission. So this is a good piece of information we use for our inpatients with atrial fibrillation. However, with our practice here, we have noticed that cardiologists, regardless of the presence of these risk factors we have mentioned, any patient with atrial fibrillation, they do order thyroid function tests for. So the aim of this study is to limit and predict who would be having hyperthyroidism. So, and in order to reserve a resource, lab resource. So what's new in the pipeline for the treatment of Graves' disease? So this study was a randomized controlled trial addressing a new medication in the treatment of severe Graves' disease. As you know, thyroid receptor antibodies are secreted from plasma cell. So the idea of this study was to generate a medication or to study a medication, daratumumab, which is a monoclonal antibody targeting plasma cell, which eventually will deplete plasma cell to produce the TRAb antibodies. But patients in this study had to have severe Graves' disease. So the aim for this study was to find the appropriate dose for the patients. So as you see here, it's a randomized, the primary outcome was to see a change in the serum TRAb from baseline and up to 12 weeks compared with the placebo arm. So what defines severe Graves' disease? So patients in the study had to be obviously above 18 years old, and they had to be having a recent onset of Graves' disease. TRAb concentration had to be above 10 units per liter. So that indicates severity of Graves' disease. Oh, and one of the below. So high free hormones, high free T3, high free T4, or persisting hyperthyroidism despite being on the thionomide for more than 12 weeks, or inflammatory eye disease, thyroid eye disease with a score of more than 3, CAS score more than 3, or 2 relapses within the last 12 months. So that defines severe Graves' disease. So this medication was in its first stage, hoping to see good results and promising outcomes. Moving on to another drug in the pipeline, specifically targeting the TSH receptor. So this is a monoclonal K170, targeting the TSH receptor specifically for patients with both conditions, the Graves' disease and the associated thyroid eye disease. So what do we have so far to treat thyroid eye disease? We do have teprotumumab, which targets the IGF-1 receptor. And I have talked about the anti-CD38 plasma cell depleting medication monoclonal. And now this one is an anti-K170, highly binding to TSH receptor with high affinity. Look at the great outcomes here. Robust outcome. One of the candidates has demonstrated improvement in exophthalmos, a reduction by 8 millimeter. Another candidate, a reduction by 6 millimeter. You can't attain this by surgery. Talking to ophthalmoplastic surgeons, our colleagues in practice, they haven't achieved or seen this result using teprotumumab. So this is a really promising medication for severe eye disease. So the main side effects of this monoclonal would be fatigue, lethargy, and diarrhea. And if you look here at the baseline, the number of TRAb antibodies at baseline and number of TRAb antibodies, their level at day 28, you would find increase in the TRAb level. So that tells us that TRAb is measured unbound to the receptor. So specifically, the receptor is being blocked by this monoclonal. And if you look here, by day 50 over day 50, the free hormones have reduced down by 50%. So a real promising monoclonal. What about another medication for thyroid eye disease? So the idea came from observing a link between high LDL with thyroid eye disease. So statins are known for increasing their action of increasing cellular apoptosis, and that is by their action on HMG coreductase. They are HMG coreductase inhibitors. They do act also on decreasing the cytokines level, like TNF and IL-1, IL-6, which some of our previous medications work on, although they are off-label. But this is the action of statin here. And the idea came linking these inflammatory markers that we see in high LDL patients and thyroid eye disease patients. So this medication, statin, would work more if a patient was a gender male and having a disease duration of more than 1 year. So what did this meta-analysis show us? So the biggest studies came from a retrospective analysis of over 39,000 patients addressing the development of thyroid eye disease. So thyroid eye disease was less likely to happen in the groups who have received statin therapy. Another study, over 8,000 people, the same thing demonstrated. However, it's worth note that the statin use should be an adjuvant treatment, not a sole monotherapy primary treatment. We still need to educate our patient on how to on stopping the disease progression and by stopping smoking, and for endocrinologists to achieve a euthyroid status and use radioactive iodine in a reasonable way if it's indicated. So it's used as an adjuvant therapy to our other measures to primarily treat thyroid eye disease. What about the teprotumumab, which has been used for the last 4 years? So this is a study addressing the efficacy and safety of teprotumumab. So this is a big multi-center studies across the US, a disease duration of ranging from 2 to 10 years with CAS score of a mild degree. So this study has addressed the efficacy of teprotumumab in low disease activity patients. And obviously the primary endpoint is to monitor and measure the improvement of proptosis and diplopia. So these are the measured outcomes which can be correlated clinically. So if you look here at the muscle volume, have reduced dramatically with a significant p-value. So those inflammatory muscles behind the eye have reduced in size. So did the orbital fat. Clinically translated into proptosis, minus 2.4 millimeter reduction in proptosis. So I was always looking at this rate when you assess the efficacy of teprotumumab in studies. So whether a patient is teprotumumab responder or not. So teprotumumab compared to placebo can prove efficacy in 62% of users, which is a good success rate. What about the adverse side effects? Mainly is the muscle spasm over 40%, hearing impairment and fatigue around 22%. There are some studies afterwards didn't find the association between hearing impairment and the use of teprotumumab. So there are conflicting studies. However, if you do have severe proptosis or diplopia, you better use teprotumumab because it does reduce these clinical outcomes significantly. This study is one of my favorite because I've always been wanting to see a comparison between or a head-to-head between IV, GC, and teprotumumab, and unfortunately that didn't happen. However, this is a meta-analysis comparing these three different studies with disease activity. So if you look acutely at the CAS score and proptosis or diplopia, number one came for efficacy was the methylprednisone for disease activity. So if you have a severe acute inflammation, you better use methylprednisone. And for proptosis, it's teprotumumab. For diplopia, it's teprotumumab as well. What about chronic status? You know that these agents can best be used during the acute phase. However, if you have a chronic status and you haven't introduced your big guns initially, so with the chronic status, with the chronic proptosis, teprotumumab was still associated with favorable outcomes, and mycophenolate did the same thing as well. With diplopia, mycophenolate did the same thing as well. However, these agents, as I said, they need to be used during the acute phase of thyroid eye disease. Again, if you have chronic activity of the disease, mycophenolate is the agent was shown here to have associated with decreased outcomes. Remember that proptosis and diplopia were not studied in IV, GC, and rituximab patients. We still use tocilizumab and rituximab, their off-label use before the introduction of teprotumumab. However, with that introduction, we might change our practice, bearing in mind the cost of this medication. Let's move on to breakthrough in cancer. So this is a phase 3 trial outcome of selpercatinib in advanced RET-positive medullary thyroid cancer. What you see here in terms of overall survival, patients with a positive RET mutation did very well while being on selpercatinib. So the overall survival was nearly approaching 100. And it did so with progression-free survival initially. So this is a great medication to improve overall survivals in advanced RET positive medullary thyroid cancer patients. The main side effects, as any other tyrosine kinase inhibitor, are hypertension, diarrhea, and increase in liver enzymes. Best responders to this medication were non-Asians and previous use of cabozantinib. Well, I think this is a culprit which weakens the study. Again, cabozantinib is a strong tyrosine kinase inhibitor. You should, not study that with a medication that you want to prove its efficacy. So what do we know so far about genome in the thyroid cancer? So before the development of thyroid cancer, some patients do harbor some mutations, but these mutations do not translate into malignancy. However, there would be a driver turning on this gene through the signal transduction pathway to promote cellular growth. With well-differentiated thyroid cancer, with the conventional type of PTC, most PTCs do harbor BRAF V600E mutation. With the follicular thyroid cancer, most of them would harbor RAS mutation. Hepatocellular cell carcinoma is a different type of mutation, which is a mitochondrial DNA mutation. With the long-standing or chronic well-differentiated thyroid cancer that hasn't been treated or surgically removed, the mutation do change. This is important when you do biopsy a site and want to start your systemic therapy. So the mutation do change. For the poorly differentiated thyroid cancer, you do have the TERT mutation being most, and for the anaplastic thyroid cancer, P10 has been noted to be associated with the anaplastic thyroid cancer. So the gene differ if the differentiation and the aggressiveness of the cancer change. That's important when you try to start your systemic therapy and prove what gene and what site you need to take this from. Again, a new understanding in the field of particularly the field of papillary thyroid cancer. So with the MAP kinase inhibitor pathway, the expression of genes for cell differentiation and hormone biosynthesis is inversely correlated with the output of MAP kinase pathway. If you do have less output, that means less differentiation. So how do a well-differentiated cancer become a dedifferentiated cancer? It's through this disruption in the signal transduction pathway and the loss of negative feedback. That's an important concept to understand for the innovation of medication targeting genes in the dedifferentiated thyroid cancer. A new entity that was defined by the WHO, tumors of uncertain malignant potential. So these tumors are difficult to characterize by pathologists. These are questionable capsular invasion or angio invasion thyroid tumor. So with those difficulty making the diagnosis, a study came up addressing, it's a single study, single center study addressing more than 300 tumors of that kind, and they have followed them up for 15 years. So those over 300 cases were subclassified into a follicular type or a well-differentiated type of uncertain malignant potential and an oncocytic type as well. Most of them harbor the RAS variant mutation. And remember, experts still consider them a benign form of tumor. But I think multi-center studies are needed to prove the same thing and to attain such a practice. So what's the most recent guidelines tell us? Everyone is eager to learn and to apply this into practice. Some of us have been practicing this already. So the nodule guidelines in 2025 have de-escalated the practice that we're doing. So doing less is considered more in the welfare of patients. So T1 now, and up to T2, you can consider lobectomy. That's a big change from the previous practice. And for T1A, you do not have to go and perform surgery. You can either do two things, an active surveillance or an ultrasound-guided percutaneous ablation. These two options are available instead of surgery for T1A stage. For tumors up to 2 centimeters, which is T2 stage, lobectomy is a choice. Up to 2 centimeters, you can perform lobectomy. That was really a big change in the practice. Maybe some of us are not confident enough to apply such guidelines in our practice based on your demographics, on your patient's demographics, on your patient's adherence to the follow-up. So what do the 2025 thyroid cancer guidelines tell us? How are we going to change our practice? So with the risk stratification, there came a new staging, dividing the intermediate class into low and high intermediate. And that is based on multifocality and lateral lymph node involvement. So the purpose for this classification, this further classification, is to narrow the index for radioactive iodine and verify which patient will really benefit from radioactive iodine. Active surveillance, as we saw, is performed for very low risk or micropapillary carcinoma. And DATA system has been implemented in the new guidelines. So what does that mean? So after diagnosing, before you jump in and perform surgery, you can assess the patient for surveillance. As we saw, up to 2 centimeters, which is T2. Sorry, you perform lobectomy, which is down escalating, but T1A, you can sleep on and perform active surveillance. So you do not have to perform surgery. This is a big change in the practice. So what are the game changers? Lobectomy up to 4 centimeters is an option. Prophylactic dissection for central compartment is not recommended. If one to consider prophylactic, probably for T4. Otherwise, it's not recommended. And if you want to perform therapeutic lateral for proven disease, it should be selective compartmental to preserve the accessory, the jugular, and the sternocleidomastoid muscle. For T1A, an option of surveillance or ablation instead of surgery. That's a really big change in the practice. I would like to invite you for a free registration in our Enriched Thyroid Congress, which we hold annually, physically and virtually. We hold it in an MDT fashion. We present plenaries. So the past presidents of the American Thyroid Association guidelines were invited to our previous conferences, and the guideline task force members were as well invited, and a fruitful discussion was generated among the speakers and the audience. I thank you for listening, and thanks for the invitation. And it was an honor experience to present in the Jordanian society.